Welcome. I'm Steven Collens, the CEO of Matter. Today, we're launching a new series, Healthcare 2040, which will explore what healthcare might look like 20 years from now and what needs to happen to get from where we are today to where we think we'll be and want to be in 20 years. For the first program in our series, we're focusing on primary care, and we've invited physician, executive, and health policy leader, Dr. Lauren Hughes, to join us. Dr. Hughes is a professor of family medicine and the state policy director of the Farley Health Policy Center at the University of Colorado Medical Center. She formerly was the Deputy Secretary for Health Innovation in the Pennsylvania Department of Health. She's spent many years focusing on the future of primary care, and I'm delighted that she's agreed to join us to share her perspectives today. With that, I am delighted to turn things over to Dr. Hughes.
Steven, thank you so much for the opportunity to kick off the Healthcare 2040 series and the opportunity to talk about one of my favorite topics, the future of primary care. We know that the research shows that primary care is the foundation of well-functioning healthcare systems. So I find it even more fitting to have the great honor to kick off this series, given what we know about primary care. So what is primary care? I understand that many of you joining the webinar today have a really good understanding of primary care, and for that, I am very pleased to hear that. One of the challenges, though, in primary care is that there are, especially in policy and practice, that there are so many different ideas, concepts related to primary care that it's important to be clear and grounding ourselves in a clear definition of primary care. This one, in my opinion, is sort of tried and true, tested over the past 25 or so years since the IOM released it, and it is the following. Primary care is a provision of integrated, accessible healthcare services by clinicians who are accountable for addressing a large majority of personal healthcare needs, developing a sustained partnership with patients, and practicing in the context of family and community. The value of primary care. This is the Cliff Notes version for you that summarizes several decades of research from Barbara Starfield, the Institute of Medicine, the World Health Organization, and numerous other health services researchers. What we know about primary care is that its value relates to its ability to focus on prevention and education, early detection and management of health problems. Patients report better health and greater access when primary care is available. We see at the systems level that it leads to higher quality and lower cost of care. Primary care can increase more appropriate and reduce potentially harmful care. It's linked to lower morbidity and mortality, generates higher value, and can lead to equitable distribution of health among the population. So let's talk about expectations of primary care, or core principles for primary care. About 4 years ago, two organizations, the Patient-Centered Primary Care Collaborative and the Family Medicine for America's Health Initiative, joined forces to re-examine two prior sets of principles related to primary care itself and the patient-centered medical home to design a more inclusive process with more stakeholders to create a set of principles that represent what individuals, families, and the public should expect from primary care. Those 7 principles that you see here were selected by a group of more than 30 stakeholder organizations, and through research, surveys, outreach to numerous primary care leaders, and ultimately a summit. And they are as follows. Principle 1, person and family centered. This is the idea that primary care is focused on the whole person, their physical, emotional, psychological, spiritual well-being, and any cultural, linguistic, or social needs that they may have. It's important that this is approached in the context of family strengths, values, and goals as appropriate and applicable. Principle number 2, continuous. One of the hallmarks of primary care are the respectful and enduring relationships between patients, families, and the primary care teams over time. Principle 3, comprehensive and equitable. Primary care takes a whole person approach with attention to acute, chronic, preventive behavioral health, oral health, and health promotion activities. As well, primary care is committed to partnering with community-based organizations to identify and address health inequities. Number 4, team-based and collaborative. Team members work at the top of their skill set according to this principle, and they're also trained in leadership and how to partner with patients and families. Number 5, coordinated and integrated. Primary care integrates activities across care settings and services and also helps patients navigate guidance that they may receive from other clinicians. Number 6, accessible. Primary care will make in-person and virtual care for all patients available regardless of linguistic, literacy, socioeconomic, cognitive, or physical barriers. And last but not least, number 7, high value. Primary care employs a systematic approach to measuring, reporting, and improving population health, quality, safety, and health equity. Are we currently fulfilling all of these principles yet? The simple answer is no. But what I love about these shared principles of primary care is that they serve as an excellent evidence-informed roadmap as we contemplate how to pivot and transform primary care for the future, particularly as we continue to move through COVID-19 and then think about our lives post-COVID-19. What is needed to help us get to fulfilling these 7 shared principles of primary care? There are many things. I'll mention 4, and then later on in the talk, I'll walk through several other ideas that I believe will help us fulfill these principles. The first is adequate investment of resources in primary care. The second, population-based payment for services rendered. Number 3, flexible deployment of healthcare workers and the broader workforce in the community. And number 4, practice coaching infrastructure and much, much more. So principles are one thing, but what do we in primary care functionally offer and do day in and day out? We do a lot. We care for all ages, all problems, all social strata. We care for men and women, children and adults, Black and white, rich and poor, native-born and immigrant populations, the recently born and those that are at the end of their life, and pregnant and non-pregnant adults. Let's dive into an example, a practical example, but a hypothetical one of a 44-year-old patient. This woman is undergoing breast cancer treatment during the very COVID-19 pandemic that we are living through right now. Overall, she's managing her chemo and radiation well, but she's worried about long-term side effects like neuropathy, when that might start, how long that might last, or maybe it won't go away ever at all. She has been in and out of the hospital multiple times for her treatment regimen, and she's concerned about exposure to COVID-19 and has lots of questions about when she should or should not be tested. She's struggling with depression because of her diagnosis, and also because she still has diabetes, hypertension, asthma, and Crohn's disease to manage. Looking ahead, she will need tailored preventive care, especially related to looking out for any secondary cancers that may result because of her radiation treatment. She's a non-native English speaker, graduated high school, and so any conversation with her about treatment plans or just broader health education need to be tailored with these 2 factors in mind. She lives alone and has a poor social network to support her during this difficult time, and she recently lost her essential frontline job as a bus driver along with her benefits, and she's trying to navigate how to get access to care. When you consider this hypothetical example, what is listed in yellow and underlined is under the purview of our specialty oncology colleagues. Everything else in white represents the body of work and those core functions that is primary care. COVID-19 has exposed deep fractures in many of our healthcare, public health, and social and safety net sectors. Relative to primary care specifically, we have witnessed the phenomenal inadequacy of fee-for-service medicine. Financial challenges mean laying off and furloughing staff. It may also mean trouble buying needed supplies or difficulty meeting the cost of reconfiguring, clinical spaces. Financial challenges may cause provider burnout and anxiety, worry about the very practices even staying open, and frustration with financial assistance applications and ever-changing regulations. There's nothing better than hearing from primary care clinicians themselves that are on the front lines. I'll share these quotes with you and then tell you about the organization that is working to collect this data. From a primary care clinician in New Mexico, primary care is a line, daily exposure to COVID-19. It's trying to keep our practices afloat. The PPP loan was approved, but the rules for using it are confusing. We need help from our accountants, and this will add to our overhead of 60% plus. New Hampshire. We lost at least 400,000 in March and April. We have a large elderly, disabled, and low-income population. We are rural and do not have access to reliable broadband. I have been able to continue to provide care, mostly by phone. Oregon. I'm a solo family practice doctor running my own clinic. I am in total panic about how I'm going to pay my staff, who all rely on their paycheck, to pay their bills and feed their children. I want to know that I can do telemedicine visits and get reimbursed by insurance and how to do that. I've tried accessing webinars that are full and feel very scared. Indiana. My revenue is down by 80% because my health system is not allowing us to bring in any non-urgent visits, such as well child checks or physicals. My health system is also not allowing us to bring in any patients with any respiratory symptoms whatsoever. It is a very depressing time for me right now because I continue to have lots of administrative unpaid work. And lastly, California. This pandemic has unmasked the inadequate support for our primary care and public health infrastructure. Telemedicine reimbursement must have parity with office reimbursement. I don't want schmaltzy commercials thanking me for being a frontline hero. I want the tools to do my job: PPE, testing, tracing, and compensation. For those of you that are not familiar with the COVID-19 primary care surveys that are conducted by the Larry A. Green Center, which is based in Richmond, Virginia, I highly encourage you to make a point to spend a few minutes today on their website learning more about these surveys. In collaboration with the Primary Care Collaborative, the Green Center has been fielding national clinician surveys since March 13 to better understand the response and capacity of U.S. primary care practices to COVID-19, as well as the impact of the pandemic. To date, 20 convenience sample surveys have been fielded, and summaries of each of these are available on their website. In addition to the qualitative data that you see here, they're also acquiring quantitative data through those surveys. And in addition to speaking to finances, respondents are also commenting about challenges with staffing, getting needed testing and supplies. There are concerns about delayed chronic care for their patients and what delays in preventive care, such as cancer screenings or vaccinations, might mean for the health of the patients they care for. They're also commenting on payment reform, space reconfigurations, and much, much more. Despite incredibly challenging circumstances, primary care has risen to the occasion during COVID-19 and has innovated at a pace rarely heretofore seen. This slide captures just a small number of the types of innovations that primary care has been engaged in since mid-March. For example, creating provider hotlines to share information about this new disease, how to test for it, how to treat it. Curbside and home visits to minimize exposure for patients. Creating drive-through testing in clinic parking lots. Literally the explosion of virtual care options for patients, and in many cases within 24 to 72 hours. Partnering with the community to create or acquire personal protective equipment. Providing COVID-19 updates via Facebook Live. And mobilizing volunteers to deliver food and medicine to patients, particularly elderly patients that are isolating and quarantining at home. Some of these innovations provide insight into what is possible to do in the future. So what will primary care look like in 2040. I really wish I had that crystal ball that could answer this precisely. But what I'm going to share with you today are sort of examples of a vision of more community-oriented primary care that I have for us in 2040, and some opportunities where we need innovation, entrepreneurship, and policy change. Before I get into those, there are two key assumptions that I'm making about primary care in a post-COVID-19 world. And the first is that primary care will increasingly be recognized as a public good. And I'm not speaking here necessarily in the pure economic definition of what a public good is, but rather the increasing recognition that primary care is a critical need that every person in this country has, and how can we expand access to these very important functions. And the second is that I'm making an assumption that in a post-COVID-19 world, that primary care will be supported in its ability to fulfill the social contract. And what I mean by that, by the social contract, is an obligation to put patient, family, and community needs ahead of our own in exchange for, particularly for physicians, nurses, and other professionals, for our privilege of being self-regulated in the work that we do. The fundamental paradigm shift, the one that I am proposing, is to make a pivot from focusing on clinic to turning our attention to community increasingly over the next 2 decades. I think it's far beyond time to step outside of the confines of a solitary office or clinic visit to the realm of the community and to really understand what those needs, and priorities, and values are of the community that you are serving as part of a primary care team. So in essence, moving from you come to us, sort of a mantra, to we're going to go to you. From moving from retrospective to a prospective mindset, and moving from a reactive to a proactive stance. So a quick snapshot, very high-level snapshot, where we are predominantly in 2020. All of these descriptors here will not hold true in all environments and primary care locations, but certainly on the whole I think are again what we're seeing predominantly for these across these 7 different areas. From an investment standpoint, in 2020 we are predominantly fee for service and retroactive in terms of payment models. From a care perspective, we are making some progress in team-based care, but nowhere near where a lot of us would like to be. From a technology standpoint, it is still the prevailing and mindset among my colleagues that electronic medical records are mostly still billing tools. They have not fulfilled their population health promise. Wearables of a whole variety are not yet integrated, and we don't yet have good mechanisms to manage that information stream coming in from those wearables. And then we still have poor interoperability. After investing billions of dollars in electronic medical record systems, we still, for the most part, have created electronic versions of paper chart problems because we still do not have interoperability across systems. From a data perspective, little connection across sectors. And here I'm not just talking about across primary care and healthcare systems, but also from health and healthcare to education, government, and other sectors. From a systems perspective, cross-system collaboration across behavioral health, public health, healthcare organizations, social sector organizations is still, for the most part, an exception, not the norm. Again, there are exceptions to this. I will say, though, that COVID-19 has certainly helped propel health and healthcare organizations to be more collaborative across systems just by virtue of necessity. Training in primary care still traditionally and largely takes place in silos. Future physicians over here, future nurses over here, physical therapists, pharmacists, social workers, and the like, all in their own silos. And learning, particularly with an eye toward rapid learning, rapid learning, innovation, transformation in the primary care space, happens in kind of a one-off sort of fragmented type of way, and not really an easy way yet to sort of plug into learnings from other systems or primary care practices. So what does a potential vision look like in 2040 across these 7 model domains? From an investment perspective, increasingly moving toward value-based and prospective. From a care model perspective, expanding the notion of who can be a part of a primary care team and to consider the phenomenal resource for sourcing that team from the community itself. On a technology standpoint in 2040, for any of you that are on the call that are skilled and knowledgeable about artificial intelligence and bots, I would certainly welcome you to speed up this innovation a little bit closer to where we are now, as opposed to thinking about this solely in 2 decades from now. But artificial intelligence to help with completion of documentation, bots to help us manage numerous streams and volumes of information to help make clinical decisions. The next, what I have there in a quote, virtual is standard but optional, is from the patient perspective. I think we have learned here in COVID-19, particularly from a primary care perspective, that there are certain conditions, certain patients, certain situations in which virtual care and access for patients in this way is really what they need and they benefit from, particularly if there's a strong working relationship that's already in place between that patient and family and their primary care team. So I see virtual as a standard offering moving forward, but still an optional one depending on tailored patient needs, and that we would get to the point where we have true system crosstalk across a variety of different systems. From a data perspective, in 2040, I'd like to see us democratize and link data across health and healthcare and other sectors in a way that we can harness that important information of patients and family members in the community to truly understand their health, how to intervene, and how to connect them to resources. From a systems perspective, would love to finally see in 2040 that a community member would not be able to distinguish the difference between behavioral health providers, public health, and primary care. That this is a seamless, integrated system providing sort of a first line of defense and level of care for that community. Training, that we will develop models to do this in an interprofessional way, and that we will be, in terms of a learning perspective, be coordinated in our rapid cycle learning approach and innovation, and again, connecting practices to one another so that you have a broader sort of a meta system of rapid cycle learning and innovation. One note I'd like to make on the investment front, and a key distinction between payment for primary care and financing in primary care. I'd love to see us also make a shift from payment to a finance mindset. Payment, it makes us think of sort of the immediate financial rewards that guide clinician and primary care teams' behavior. It's about cost, about units. And financing calls upon us to have a longer-term vision and an investment strategy to improve health. And as primary care professionals, from my viewpoint, we are stewards of health, not stewards of cost. And so I want to call out that particular distinction. So where do we need entrepreneurs, and where do we need policy change? We need them in all of these areas. And on the ensuing slides, I'm going to walk through each of these models in turn and offer some ideas, suggestions as to where, along these 7 dimensions, where we could be in 2040 and what we might need to innovate between now and then. So let's talk first about investment models. I'd love to see us in 2040 be able to prospectively finance value-based primary care that truly improves health. This may involve allowing primary care teams the ability to, with a prospective set of funding, to be able to tailor services to match community needs, norms, and values. I'd love to see clinical performance being accountable to community determined, not necessarily payer determined, health outcomes. It'll be critical to make sure that models are rooted firmly in the value of relationships, which is a hallmark, an enduring hallmark of primary care. And I could see us in 20 years from now, a rising trend of community-owned primary care, again, moving toward perhaps the more economic, the true economic definition of a public good. And I know that this would also be welcome in 2020, but certainly public and private payer alignment across quality measures, reporting, and documentation, and thinking about designing financing that really accounts for hallmarks of primary care of education, wellness, and prevention. Care models in 2040. I would love to see us expand the notion of the primary care team, again, going to the community itself, starting much earlier in the pipeline than just thinking about how do we get high schoolers interested in healthcare careers or get college students into medical school. If you pull in members of the primary care team from the communities themselves, they're more likely to understand the needs and the priorities and the values of that community that helps fine-tune the efficacy of the primary care services that are delivered. Would love to see patients have a full understanding of their primary care team, and that we finally figure out ways with new payment or investment structures to completely overhaul and reschedule a primary care day to allow patients to schedule with the primary care team more often and to have appointments that are of adequate length for the concerns that they are bringing in. And then thinking about how we structure the primary care team. Would love to see this be done not from a role or a position-centric position, but being done from a deep understanding of community needs and priorities and primary care functions. And you see a variety of different options here. This is not an all-inclusive list. There might be many other types of professionals, particularly in the social sectors, that you'd also want to fold into the primary care team. Technology models. In 2040. I'd love to see us build smart, integrated tools to aid both providers and patients. On the provider side, again, as I mentioned earlier, artificial intelligence will be here much sooner than 2040, I am certain, already in development, already applied in many cases, but thinking about AI to help with documentation needs, again, bots to help with clinical decisions, and EMRs to deliver on their population health promise. Particularly in rural settings, would love to see increased access to smart integrated tools, e-consults, e-education across systems on a provider-to-provider basis. It allows maybe more rural or remote primary care practices and systems to care for more complex care and to keep that care local. On the patient side of things, again, virtual will be a standard offering, or it should be a standard offering moving forward, but I see it still remaining as optional depending on the underlying relationship with the patient and depending on really fine-tuning services to meet patient needs, again, in the context of cultural, linguistic, and other social factors. I will be so excited to see what a future primary care day looks like from a scheduling perspective. So much need for innovation in this space. What is the right combination of low tech, like a phone call, or high tech, video technologies, in-person, home visits? What's going to be the right combination of different ways to access and connect with your primary care team based on the community's needs? Wearables and remote patient monitoring devices are here to stay, but right now they're not integrated with EMRs in a way that allows us to efficiently access or use or apply that data in any way. And we also, again, have to think about ways to manage that additional volume of information that will be coming in to primary care teams. One note of caution, though, that I would say, and I've been following this sort of chatter, chatter in in different groups and different audiences is that there's this excitement that technology could wholesale take over, or for primary care, or many other types of healthcare services in specialties. I would caution us against thinking about that and thinking of technology as a very important adjunct and tool to help us be better and smarter and more effective and more connected in primary care. But again, with the basis of relationships to primary care and how to deliver those services, it'll be really important to maintain the focus on human connection and presence. And how do we do that in light of these new technologies that will be coming increasingly online? Data models in 2040. I would love to see us get to a place where we can democratize and link data across health and healthcare sectors, as well as social services, education, and government. True interoperability and sharing of data across these sectors, again, to harness that valuable information to understand community health and to connect patients to resources. A key point of being able to understand what local resources are available to you, here is another option for engaging community members in the act of asset mapping, for example, to understand what your community has to offer. With better data allows us to make better decisions. We could more easily retrieve and review data. Would like to see us get to a place where we can have fewer errors, better quality communication, population health dashboards, and the like. What about systems model issues in 2040? I think it'll be really important on a community-to-community level to integrate systems for optimal health outcomes. So again, to truly think about behavioral public health and primary care as a strong, united front and foundation for the healthcare system that very much work in complementary ways. And I think, again, this is something to be grateful for in many ways for COVID-19, for exposing those needs and those interdependencies that we have across these different fields. It'll be important for us also to learn skills on how to authentically partner with communities, with patients and families, and also employers. If in 20 years from now we still have a fairly predominant model of employer-sponsored insurance, it's important to engage and invite employers to that design table to think through solutions and what we need to change moving forward. And then to think about that broad primary care team, how can they also additionally be viewed as leaders in the community and in various community systems? Training models in 2040. Would love to see us get to a place where we can advance truly interprofessional care and what I call sort of whole health training. It'll be important in these future training models to learn to care for patients alongside other professions in that community-based team, while still paying attention to the importance of achieving clinical excellence collectively as a team. As we look ahead, especially with increasing data availability, increasing technologies, and who knows what sorts of health and healthcare challenges and finance or quality or access or what have you that we'll be addressing in 20 years down the road. But I most certainly see a need for those of us in primary care to increase our training and adaptability and flexibility in such things as the complex adaptive systems when it comes to problem solving, epidemiology, and other fields. We'll need to figure out and embed this in training, but how do we develop sense-making approaches to navigating, interpreting, and applying information that we're receiving from multiple sources, whether it's from the community, whether it's from patient wearables, et cetera. I see us increasingly going upstream, that is to say, to focus on social factors that can be the root causes of poor health for many patients and families that we see in primary care when we're providing clinical interventions. And those are things, thinking about how to intervene in early childhood to make sure that those children have a healthy start in life, focusing on nutrition, exercise, how to manage and address mental, emotional, and behavioral health. And then lastly, to look at alternative models of financing primary care training. Could we involve philanthropy? What about private businesses, healthcare systems, community-based organizations or alliances? Are those options that we have to really support the notion of community, based or community-oriented type of primary care, vision for the future? And then lastly, being able to get to a place where we can create personal learning profiles for learners and primary care teams as they progress through their training. And then learning models in 2040. What is this going to, to look like? I'd love to see us be able to promote rapid cycle learning and innovation in primary care. That's an expectation, and that's a reality of what primary care does in 2040. I can see this happening in a variety of different ways. The first is to launch a nationwide primary care extension program modeled after the very sort of successful agricultural cooperative extension program that has revolutionized farming practices over the past 100 years. What can we learn from that approach to help provide training and technical assistance and resources to primary care that wants to continue to innovate to better meet the needs of their local communities? I could see this through creating regional primary care incubators that fully understand and appreciate primary care complexity and all that goes into the functions that we provide. I could also see dedicating local community or primary care staff as part of the primary care team, having 1 or 2 staff members that are solely focused on innovation and learning, that are looking out to other primary care teams and practices and communities within their state at the national level, that are connecting to the regional incubators, that are connecting with and interfacing with a primary care extension program, again, to underscore that expectation that rapid cycle learning and innovation will be a hallmark and will be an expectation of primary care practice. And then lastly, to develop a formalized national network of primary care research centers that evaluate new models that come to fruition and provide implementation technical assistance. There are several of these primary care research centers that exist currently, and they work informally together in a collaborative way, but it would be something to explore whether there needs to be a more formalized national network of such centers. And the last issue that I'd like to talk about, and I look forward to the fireside chat with Steven and hearing what your questions and thoughts are, is some suggestions on principles of engagement when it comes to thinking about entrepreneurship or policy change in primary care, given its vastness, given its complexity, and given its sort of multiplicity of functions that it provides. And the first is, if you are interested in innovating or being an entrepreneur in the primary care space, please do whatever you can to master the complexity or your appreciation thereof. Primary care needs you to understand the full breadth, scope, and perspective in which we do our life's work. Number 2, to partner with primary care and carefully listen to and learn, respect their lived frontline experiences, and invite primary care team members to the design table to iterate with you over a new venture or what have you. Number 3, commit to the long term. Changing primary care requires vision, ample time horizon, and adequate commitment of resources. Number 4, choose your investors wisely. Strike the right balance between social responsibility and profitability. Both are important, and it's important to identify investors that appreciate and know the distinction between those two. Number 5, be courageous, take risks. Be prepared to fail, engage in rapid cycle learning and innovation. And number 6, please share your successes and failures, and again, inspire us to join you in this primary care entrepreneurship venture. Happy to share references for today's talk with you, and then also, and I'll work with the Matter Health team. Be pleased to share my contact information with any of you. Would be happy to have follow-on conversations after today's presentation.
Lauren, thank you so much for your presentation. There is a lot of great content there, and so many different areas where I could see wanting to, or I would like to explore more of your thinking and your thoughts. But maybe I'm just going to pick a few because we otherwise we'll be here until Sunday. So one of the things you talked about was this paradigm shift of kind of you come to us versus we go to you. And part of that, some elements of that we're even seeing today, which I think is really one of the most interesting aspects just on the technology side of what we're seeing is really enabling a healthcare sort of delivery model where that's much more intelligent and proactive. But one of the challenges that we always see in primary care or just in medicine is that patients who are people who are set reminders for their annual checkups, or anything else, they don't go, or they don't follow their treatment protocols, or they don't follow up on specialist visits, or trying to change behavior of people is one of the holy grails of innovation that we see from a technology point of view, process, kind of across the board. And I think a number of the things that you talked about as to how primary care in 2040 will look depend on some elements of behavior change that aren't obvious today. And I'm wondering, what's your view of how we accomplish that?
Great question, like that $1 million question, Steven. So I appreciate you, starting with that to begin this part of the conversation. And I think, trying to work with patients and help them change behaviors to become healthier or adapt healthier lifestyles is a constant challenge that we face in primary care. But primary care is also well suited to address those challenges head on. As you heard a common theme throughout my presentation, that primary care, and why I love it and why I chose family medicine as my particular primary care specialty, is I love having the longitudinality of relationship with patients. And that relationship is not constrained to the confines of your clinic exam room, right? That relationship can extend in a variety of other ways, virtually, in person, at home, group visits, and what have you. But for patients that aren't engaging or do not seem to be readily engaging in education or prevention, this is where you or I would, as a family physician or a member of my primary care team, would reach out and really understand what's going on for that patient. Are there any number of social factors that are impacting their ability to engage with their health? Is it housing instability, food instability, transportation? What are those factors that might be impeding their ability to do that? And the second, really get to understand a patient's philosophy, sense of values relative to manage their own health. Is there something there that would be important for the to know so that you can tailor a response to engaging with that particular program? Every one of the conversations provides an opportunity to learn about your around wellness and prevention, generally speaking. So those would be some tactics that I would pursue, have pursued, before, and could readily be pursued in that future sort of primary care team, community-based sort of vision to really understand what's going on for patients in the community and to connect with them and get them connected to needed resources.
And I'm intrigued by this. You talked about community a lot during your talk, and you just sort of touched on it again as really a cornerstone of how kind of the house of primary care is built in the future. The reasons we don't have that today, I think, are myriad, but among them is how we pay for primary care and just how we pay for healthcare today. Can you talk about what is you did talk a little bit about it, but just go a little bit deeper into, what does the financing model look like that enables the kind of this community-oriented care model that you're describing, the kind of outreach that you're describing, the kind of longitudinal relationships, which I think most primary care physicians would love to have more of with their patients than they really are able to today, largely tracing back to the financing, the ways that we pay for and structure the economics of healthcare.
No, very good question, Stephen. And, I want to be very clear as to why the predominant fee-for-service payment model does not work for primary care now, and it certainly is not compatible with a 20-year vision. First, as we all readily know, fee-for-service is tied to volume, and you're incentivized to do more. Well, the more you do does not necessarily lead to good healthcare outcomes, and it actually can cause physical and financial harm to your patients. Number two is that when volume-based payments are attached to retrospective services that you've done in the past, it doesn't allow you to be nimble or to anticipate or plan what your community may need and put those sort of services. And third, for a lot of the functions, especially around wellness and education and so forth, there are no existing fee-for-service codes that allow primary care teams to bill for services like working with community health workers, quality improvement work, non-face-to-face visits, and this really impedes innovation and transformation. So in general, when I think about payment, I'll address payment and I'll touch upon financing. When I think about payment, I am generally a fan of any kind of movement toward prospectively paid, risk-adjusted payments for primary care that take into consideration patient and community level, risk factors. And personally, I'm the biggest fan of a global budget model for primary care practices. Now, granted, that's kind of on the very far end, especially when you consider risk and how to manage that and how to innovate and transform in the context of a global budget for primary care. That's on the very, very far end compared to where we are with fee for service. There are other options in between, like a blended fee for service and capitation, or pay for performance, or shared savings, et cetera. Each of them have their own, concerns or issues or limitations. But as we move, regardless to wherever you are on that that progression of fee for service from volume to value, it's going to be really critical to make sure that any prospective payment includes adequate education for primary care teams and how you deliver services in a value-based world. You cannot underestimate how strong the fee-for-service imprinting is. And it's going to take a lot of engagement and education to be comfortable operating in a variety of different perspective models that include different levels of risk, one-side or two-sided risk. It's also important to make sure that any prospective payment adequately addresses the chronic underinvestment in primary care. So that is a concern when you think about appropriately setting those prospective payments entirely on retrospective history and data. And most certainly would love to see in any prospective payment model as we move forward that it also engages both public and private payers. Imagine how frenetic it would be to try to operate in a primary care team where your public payers are on a prospective basis and your private payers on a retrospective basis. That is just a setup for a lot of major headaches. And last but not least, one comment that I would make on the investment on the investment side. I think it's very much worth paying attention to a variety of different sort of primary care spend proposals that are out there on a policy, moving forward, so that we can decide, again, with an eye toward a community-based sort of future primary care vision. How do we want to invest our dollars in technology and infrastructure and broadband, especially for rural communities? How do we want to invest our dollars in the training of that primary care team in the context, of community? There are lots of exciting options if we start to lay out a primary care investment strategy that is inclusive of, but also beyond just thinking about payment and the mechanisms of payment.
So we just have a few minutes left, so probably the last question, but are there areas of the country or specific health systems or specific businesses or specific payers that are kind of, X number of years advanced already, either because of the payment model or because of the care model that they've developed in spite of the payment model, or because of the training, or, as you look across the landscape of primary care, where are the shining stars? Where's the one where he's like, that's, much, years advanced from the average, and we're going to follow them because they're leading the way towards 2040?
No, great question, Stephen. There are three examples that come to mind, and each of these examples illustrate sort of an early precursor of, those kind of three different models in that future 2040 vision. The first is one actually that I believe is a partner of Matter Health and is in your backyard, but the MAPCore program through University of Chicago. And this is an example of a data model and a training model too, that I absolutely love, and the vision of Dr. Lindow in creating this, but engaging high school and college-aged youth to do community asset mapping and to understand where there are resources that then feed into a broader database that is available to primary care teams and other providers to connect patients with resources to help them get healthier. That is an example of a shining star that I've been tracking for a good while. Another one is one that's it's much earlier in its evolution. It's here in my new backyard here in Colorado, is an effort, a university community partnership between the University of Colorado and a local FQHC system here in Aurora, just on the east side of Denver. The goal of this partnership is to create a robust primary care and broader social sort of sector model that's going to address the key needs of populations in the three neediest zip codes within Aurora on the east side of the city. But what I'm excited about, and this sort of is an example of as a training model, that the plan is within 3 to 4 years to have a community-based training site on this campus for family medicine, general pediatric, and general internal medicine residents, along with others. So really taking that broader primary care team training approach in the context of community. And the third shining star that I would offer up to you is one that sort of aligns with the learning model of the future. And these are our colleagues at OHSU, Oregon Health and Sciences University, in Portland, in the Department of Family Medicine there. Very quickly at the beginning of COVID in mid-March, they created a toll-free hotline, and they rolled it out in 3 phases. But the ultimate goal was to get COVID-19 questions answered. The first rollout made this hotline available to current OHSU patients. The second rollout to Oregonians that didn't have access to a primary care team. And then thirdly, and the part that I'm most excited about, is that they made this hotline available to clinicians and primary care teams, clinic managers all around the state that were trying to seek advice about how to care for COVID-19 patients. This is a good example of a precursor to what a primary care extension system could look like in the future to provide that training and technical assistance and support for that may not be near an urban center or an academic medical center.
Lauren, Thank you so much for your insights, for joining us. Really appreciate it. To everyone who is watching, as a reminder, if you opted into the virtual networking when you registered, you have an email in your inbox from k@matter.health. You'll see 4 options based on different topic areas in primary care. Choose the Zoom networking session based on which topic you're most interested in. This particular program will be, we've recorded it, it will be available on our website, matter.health, in the coming days. We also have a number of amazing programs coming up over the next several weeks, including one a week from today, where we'll showcase 5 terrific Canadian healthcare ventures that we've been working with for the last several months, including one company with a novel device and a system for helping people with swallowing disorders. I haven't seen anything like it. You can learn more about all of our upcoming programs on our site at matter.health. Lauren, I love that you mentioned Dr. Stacy Lindau and her work at NowPow, which is her company. The manifestation of that work is indeed a Matter member, and we work closely with them, and they're doing phenomenal work. Thank you again for joining us. Thanks to all of you, and enjoy the rest of your day.